Okay. All right. Well, good morning, everyone. Welcome to our quarterly coalition meeting. Looks like right now, I think we got, trying to get a quick head count about how many folks we got on the call right now. Let's see. As far as participants, looks like we have about 33 in the meeting on the call right now. So we're going to go ahead and start with our roll call. Hopefully you all got copies of the slides, and for those who are joining via Teams, you can see the slides on, in front of you. So we'll go ahead and start with our traditional roll call, starting with our hospitals. Anderson Hospital.
Eric's here.
Eric, you are on your third meeting potentially at this
Yes,
point.
sir. Yes, sir. Thank
Glad
you
to
for
have you.
noticing.
I just listen by proxy through Mike's office, so I try not to get too bogged down. I know you're tired, but we're gonna make it through. All right. Alt Memorial.
Hey, Phil, it's Ashley and Brian.
Good morning, Ashley and Brian. All right. Boyd. Let's see if we got Nancy in. Boyd, if you are on, if you join a little bit later, just let me know either through chat, or shoot me a text or email. Carlinville Area Hospital. How about Staunton?
This is Sue. I'm here.
I'm about to say, I see you online, Sue, so gotcha. Fayette County?
Kendra's here.
For the hospital, is Tina on?
Sorry.
It's okay, but I'll know when we get to you over at the health department that you're here. We'll see if Tina can get unmuted or if she joins a little bit later. All right, Gateway.
We're here, Danielle and Rick.
Thank you, sir and ma'am. We'll go with our HSHS partners, Holy Family. St. E's.
St. E's is here, Brad.
Brad, you're on your third meeting as well. Welcome. St. Joseph Breeze and Highland.
Hi, Phil. This is Sonia. I'm here.
Gotcha. Thank you so much.
Phil, I can
Jersey.
use the representation for Breeze. This is Mandy Ennan.
Okay. Thank you so much.
I do Breeze and Highland, so.
I gotcha. Nope, I know. Perfect. Thank you.
Thank you.
Jersey.
Kelly here.
Kelly, hey, how's it going, bro? All right, let's see. Before Memorial, you got myself, Scott Klosterman's on, Eric is on. Lee may have joined. I know he's got some things going on this morning, so he's working remotely. So we're here for Belleville and Shiloh Memorial Hospital at Chester, Georgia. You on? George, did you just say something? I saw something pop up for a second. Okay, we'll see if Georgia can get on. All right, OSF St. Anthony's.
How you doing? Denny Stanford's here.
Gotcha, sir. Thank you so much. Redbud. Redbud Regional. Nope. Sparta. Touche.
Eric's here.
Gotcha, Eric. Thank you. All right, with our health departments, we'll start with Bond County.
Terry, I'm here.
Gotcha, Terry. Calhoun. Clinton County.
Trisha's here.
Gotcha. Eastside Health District. Anyone from Eastside? And Kendra, we got Fayette. Greene County. I got you, Charmaine. Thank you so much. I see you. Greene County. Jersey County.
Heidi Carter's here.
Gotcha, Heidi. Thank you. Macoupin County.
Derek's here, Phil.
Gotcha, Derek. Thank you. Madison County.
Michelle's here.
Michelle, you have made it to the other side almost. I haven't heard from you in so long.
Let's not jinx it. No.
All right. Monroe County.
Vicky here.
Gotcha, Vicky. Randolph.
This is Angie. I'm here.
Gotcha, Angie. And St. Clair County. Mila, are you on by chance? If so, shoot me a text. Okay. Just our other partners and community partners. We'll start with our RMSC. Greg, you on?
I am on, sir.
And Beth, does anybody know if anybody's filling in for Beth? Is Beth?
I
think
don't
she-
believe that's that.
Yeah.
Okay. All right. Any of our BJC partners on? Any of our EMA partners from any of the counties on St. Clair County? We'll start with you guys. Any Madison County? I'm hitting the folks that will traditionally show up. Monroe County, EMA. Nope. Okay. MedStar Ambulance.
Chuck's on, John's on vacation.
You authorize that, Chuck?
Everybody needs a break.
You're absolutely right. I told John that when I last talked to him, so good on you for getting him some R&R. Abbott.
Hi, Phil. Leslie from Abbott EMS is on.
Awesome. Good morning, Leslie. Any of our other ambulance services on?
Jeremy with Mosquito.
Gotcha, Jeremy. Thank you.
Rebecca Hartman with Columbia. I'm filling in for Kim. She's in a staff meeting.
Kim's in a staff meeting. What's going on there? Hopefully she's putting me in for a raise. That's what I'm asking for.
Me too.
You deserve it. All right. SLU. Helen, you on? No? Our Scott Air Force Base partners. And last but not least, our STARS crew. Any of our
Morning,
STARS?
Bill. This is Dale.
Hey, good morning, Dale. Glad you joined us. Appreciate it. All right. Well, any alibis? Any folks that weren't called that aren't listed here that we can get recorded on the call?
Molly Peterson Green.
Hey, gotcha, Molly. Thank you.
Thanks.
And Steve Heine, also on here from MedStar. I had to mute his mic for him.
Hey, no problem. Thanks, Chuck. All right. If you do by chance can't get unmuted, or if you can type in the chat, just let me know that you were here. We'll go ahead and get started. I'd say we don't have a ton to go through, but we will hit our traditional agenda as normal, starting with our COVID update, then our traditional team members across the region, and some I won't say new business, but kind of open floor discussion of some things that we've been discussing over the past 2 months, 3 months. We'll start with our region COVID census. I mean, how does that look? I mean, that is, wow. The curve has bent all the way back down. How long can we hold on to this? I'm hoping for eternity that we stay this way. And primarily, I think we're here right now because of our vaccination status, and we'll take a look at that. So again, very good trends. Hopefully you guys are seeing relief on the front ends. Now I know that we're getting some higher censuses across the hospitals with more traditional ailments. So hopefully your staff is are able to work through whatever staffing challenges they had with COVID and are able to deal with their traditional staffing challenges, which I know present all kinds of difficulties for each of you, but the numbers are looking good. Hopefully we'll continue this throughout the remainder of the summer and into the fall. I also put here, these are our patient expirations through May. And as you can see, we're finally really, really low down, back to lower than our lowest time. Looks like in July of last year was our lowest, and now we're actually below that. And those are deaths per day in hospitals that were COVID positive. So we've made it a very long way, and hopefully this number does not increase any further. So great work for the teams out there. As far as other COVID census data that we do have out there, at least our positivity rate has been remaining steady at 2.1% for the last 3 to 4 days, as reported through IDPH. So those numbers are great. ICU bed availability now is 31%. We've seen it higher. We've seen it as high as 36% over the past month. But that COVID positive or PUI volume in ICUs is just very low. So great to hear that or to see that. So we'll keep cooking with hot grease there. As you can see, as far as vaccine data, doing outstanding. Shout out to Monroe County for 41% fully vaccinated. You guys are killing it. So great work out there. As a coalition, we're at 33% fully vaccinated. So 1 in every 3 people, when you look to your left or your right, if you're the one that's vaccinated, maybe the person to the left and right of you aren't. I don't know how well to take that, but that's fully vaccinated. I think as far as across our region, we're closer to 55% with at least 1 vaccination, which is great across the region. So and the state, I believe right now is at 41% fully vaccinated, like 41.8% total fully vaccinated. So we're running behind the state a little bit. I know a lot of that's because of our dense population areas up in Chicagoland. They're still cooking pretty well with getting vaccinations there. But we're a little more sparse down here. So that demand for vaccine, as you guys already know, has really bent backwards. So you have a lot of your sites closing down. I know our major site here in St. Clair County is closed down. Michelle, are you guys still running your MassVac site?
Yep, we're still operational for at least about 7 or 6 days a week.
What's your volume looking like?
It's dropped drastically, but we have been hitting. We were doing into the thousands, and now we're into the hundreds. Of course, we're trying to hit 200 at each of these sites.
Well, that's good. I mean, that's really good. Have you guys seen has much more of that volume increased for the younger age group? How much of that are you guys really seeing?
Yeah, we've seen an increase, and I'm sorry, they just gave me numbers today, and I don't remember what it was. But we are seeing an increase within that age population. We also have been working with several pediatric offices too, who are seeing majority of those individuals.
That's great. That's great. So it's good to hear that you guys still have that you're getting that kind of traction. We still have vaccine spots open here in St. Clair County, just not on the largest volume that we had going. So, but it's good to hear that you guys are continuing to get that kind of volume through, and hopefully that'll keep pushing your guys' numbers. Anyone else out there have a county where they're still running? Maybe a MassVax site, or, even if it's not on as a larger scale as they were doing over in Madison County or here in St. Clair County. Anybody have any sites still going, and what are your volumes looking like?
Well, this is Michelle again. I know with the MassVax clinic, we're also doing several mobile sites each day pretty much for the next week. So we're also trying to expand teams to identify locations.
Got it. Thanks, Michelle. I know when Sue, a little over a month ago, you guys were doing your clinic there. How are you guys doing? Have you guys shut that down?
Yeah, we did the one clinic, and then this last Saturday was the follow-up vaccine for that clinic. Um, we did just under 100 people for those clinics, and they decided not to do the second one at that time because everybody else was shutting down their clinics and they weren't getting, the response that they were wanting. So administration decided not to do a second clinic at this time. They're going to hold back and wait for a couple summer months to go by and then discuss with the public health department if a second clinic is needed, that we'd be open for. But for right now, the one clinic was very successful. We did very well pushing people through, and we did just right under 100.
Awesome. Every vaccine counts. I know last week I was actually able to take some PTO. I went camping. It was my first trip I've been here, 10 years now, I think, in the area. And it was my first trip to the Ozarks. So we went out camping to the Ozarks. And as always, you forget some things. So I had to stop in Walmart, and I went into Walmart there. And, it was a mixed bag with folks masked, unmasked. This is my first trip kind of really out in the fray. But one thing I did notice that was really great, I thought, was that the way the staff and the patrons there kind of respected everybody's boundaries, and they, kept running these, I don't call them ads, but, over the house kind of reminders on, what the precautions are and how Walmart saw, at least that Walmart, because the Walmart here doesn't do it, saw where we were at in this present time with vaccinations and the current, stances between different businesses. And it was really good to see. And then they were continuously running ads there for their vaccine clinic that they had. And while I was there, I saw 3 people get vaccinated, which I didn't think I would see because I haven't seen anybody get vaccinated here at this Walmart, but at this one spot down there, they were doing it. So I'm glad to see it out and more prevalent in the area, and people are still getting vaccinated, even though it is at a slower rate. Hopefully, we will get to maybe somewhere around 60 to 70% fully vaccinated across the entire United States. I think we can reach some of those numbers here across the state and across our region in the greater St. Louis area. So hopefully those things will continue. So Dale, before you chime in, I was going to ask you a question. I'm going to wait till we get to your slide. So if you could kind of prep your mind for some last, maybe some vaccine stats or some things like that, or what's going on in the St. Louis area, that would be great. So, all right. Anyone else have any other data, vaccine, COVID related that they'd like to share, where they need support in, or anything like that with regard to COVID or COVID vaccines? Okay, I gave 4 Mississippis at that point. So, okay, we'll move on to the regularly scheduled programming. So we're going to start off with IDPH. Greg, any IDPH updates?
Actually not a lot because you pretty well covered the COVID statewide. The numbers are looking good. There is the goal of around June 11th to reopen completely, but that's just, I haven't seen the actual press release or anything like that yet. So kind of got to wait on that before, we start jumping up and down, especially if you're a business. The only, and I'm not going to touch on HPP because I know you're going to do that. The only thing that I really wanted to bring up again is the bed reporting. We got another monthly today or yesterday. We had a few of our hospitals who aren't in compliance, meaning either they had a month in the last 3 months that were below 70%, or they're averaging over the past 3 months less than 90%. So I did shoot emails out to them, and so just as a reminder that they're still looking at all of those numbers, and congrats to the hospitals that are having really good compliance in the 97 to 100. A lot of hospitals are doing that. But even in the EMS meeting today, it came up the importance, you know, at what some of these other facilities are looking at bed numbers, and you know the importance of the accuracy as well as getting the numbers in, but the numbers that you get in being accurate, so that EMS knows bed availability, so that hospitals know what's available elsewhere. So just when you're sitting in your preparedness meetings, and I know a lot of you don't, this isn't your wheelhouse that's been assigned to you. Just when you're sitting in those preparedness meetings, just try to reiterate how important the numbers are. And they're not just the state making you do something on a daily basis, but that people are looking at these. And in the future, probably more people are going to be looking at these bed numbers as we move into more legislation like recently happened regarding regional mental health plans on how to transport mental health patients. Things like psych beds available here as well as throughout the state are going to become increasingly important to know accurate, good numbers. So thank you to those who are doing the bed numbers. And if you can reach out to those that I sent emails today, to those folks in your hospital who are responsible for this, and ask them to please try to step up the game and meet the compliance. And that's pretty much all I have, Phil.
Thank you, Greg. First, any questions for Greg regarding that before I even say anything? Okay, so yeah, we received that update from IDPH from Dan Lee yesterday. I'll forward that out after this meeting. I'll just forward it out with the links to the YouTube when it goes up. So this afternoon, everybody will get a copy of that. So yes, congrats and thank you for all those who are very consistent in updating those bed numbers. But we talked about this maybe a month ago with regards to, maybe a little over a month ago, with regards to the critical shortage of psych beds. So that's going to be something that's going to be looked at much more intently. I mean, as we know, we don't have that large of a capability on this side of the river, but we have to be able to still accurately reflect what we do have. So it's only going to help enable our EMS services and the other hospitals, you know, our partners here in the community, better manage those numbers. I try daily to, you know, I find myself trying daily to, you know, encourage our staff here to use EM Resource as at least a spot check before they start kind of calling blindly across the region for specific information, but to use it. But I do understand that, you know, it's garbage in, garbage out, and it's sometimes a delayed product, right? It's not real-time data. So, and not just looking solely focused at the psych beds or the psych issues that we kind of have, but just generally speaking with bed availability, you know, it just has come up several times with those psych issues. So in our coalition plan, we do have some triggers in there that basically say, in our response plan, that basically say, you know, when we should increase, you know, bed reporting. You know, we did that initial portions of COVID where we went to a portion where we're doing 3 to 4 times, I think 4 times a day we were updating. Not sure outside of IDPH, not sure how well that was received or used by any of the other hospitals or EMS agencies during that time frame, because it's still slightly a lagging indicator. Even if you're doing it 4 times a day, it's still a lagging indicator. But we've got to, I think, you know, if you guys can start to think about how we can better prepare or put ourselves in a situation where we can share that information more readily and it's a little more real time. EM Resource is a great tool, but it just sometimes hard to get that information out in a time where it's actionable and, can actually support whether it's the hospital or the EMS service, in that actual time of need. So again, I will send out those numbers today. So hopefully you'll get a chance to see that. All right. We're going to skip over. We're not going to skip public health departments, but I know Beth's not on. But any public health departments, would you guys like to make any updates or provide any updates? I wasn't here last week, so I didn't attend the LHD call. I normally try to listen in on those. Any other major updates outside, maybe not even vaccine related from the health departments? Okay, that's 5 Mississippis. So one thing I will bring up, I know Terry and I have been having some conversations. Terry Everett in Bond County have been talking, and maybe we could talk about some of this offline. I want to pull Greg into the conversation, but I know we've been looking at deliverables. As most of you guys know, every year when we have our grants, we have a given set of deliverables, things that have to be accomplished within a given time frame, and those aren't always within that grant year. Sometimes they're 3 years out, 4 years out, but a part of that budget period regardless. So there are things out there. I think we're starting to see some things start to kind of conflate between the public health departments and the HPP grant. So you have the FEP grant and the HPP grant. And so for the one thing that I'm talking about now, it's like burn surge. I think we need to probably have a conversation, Greg. I don't know if it needs to be with Teresa and Katura and crew, but I think there's some requirements that are in the FEP grants that don't, fully align with the HPP grant, and I'll use the burn surge as one of those. And sometimes they're not directly aligned. And I know we look at these grants all the time, but I don't know if we're looking at them all together with all the deliverables. So putting the FEP grant next to the HPP grant, next to whatever other grant that may be out there. Because when those aren't kind of congruent, they're not running together, they're not running parallel, I think it puts us in a position where we have to do multiple things. And if the HPP grant says to do, go down this path, but the FEP grant says to go down this path, but to do it with HPP partners, you know what I mean? It puts two different grant requirements on top of us. And I don't know if that's helping or hindering it, hindering our moving forward with some things. So have either of you, has any of the health departments or Greg, have you heard of them trying to kind of put both of them in the kind of the same lane a lot of times instead of conflicting?
Well, we actually have 3 grants that we do in the region. The health departments have 2 grants, and that is the FEP grant and the CRI grant. The issue is that Katura oversees the people who do the FEP grant and oversees the people who do the HPP grant. And I do think they try to draw that together, but it's kind of a double-edged thing in which, and this is kind of coming into my personal opinion, until COVID happened, we didn't really work together all that well. I don't think, once again, my personal opinion, the hospitals with the health departments, we kind of looked at them like that's their thing, and the hospitals like that's their thing. And then COVID happened, and we found out how much the information sharing and the working together really helped that response. So I would hope moving forward that we maintain some of the relationships that we created through this COVID, that we can look at those. And I know Beth has been out a lot recently. Hopefully she will be back very soon. And she is a major player in that FEP and CRI grant deliverables. And I think could do a great job, you know, in assisting us to try to align all that to get that together. I certainly will let them know your concerns. The problem is sometimes the feds are the ones that are not looking at the requirements. You know, they're saying the state has to do this in the FEP grant and the state has to do this in the HPP grant. And sometimes they are at opposite ends. And sometimes there are things that you can't just do together, even though that seems to be more the requirement. And it certainly is more of a requirement now in the HPP grant, you know, which probably needs to change its name because it's really not the hospital preparedness grant anymore. It's the coalition grant.
True.
So there's a lot of issues, I think, to be worked out, but I think there are some ways of doing it. And if any of the health departments want to weigh in on that, it would be great.
Phil, this is Michelle. I agree with Greg. I think when Beth, I mean, has the most knowledge when it comes to these types of grants and can really definitely align both of them. Fortunately, with us currently, we haven't really received much updates regarding grants. We really don't have a reliable or I guess knowledgeable type of person to really kind of work with currently. So hopefully when Beth gets back, then we can have more feedback.
All right. Well, this is definitely something I think we'll have to really follow up on because I want to be able to make sure, you know, I want to be able to help, you know, if we're working together, I want to make sure everybody's meeting all their deliverables. But, you know, sometimes, you know, some things I can't directly impact if it's kind of going the opposite way of the path that we need to be going down at the time based on the year, you know, the budget period. So, okay. All right. Well, more to come on that. I'll see if we can, you know, arrange something in a discussion to try to find some common ground here. And it may not happen this year, but I'm trying to look at the outgoing years to try to make things a little easier. All right. So start. Oh, I'm sorry.
I think when Beth gets back and get Greg, Beth, and maybe you and I together, really kind of figure out where we're going for this for the next year.
Yep. No, I appreciate that, Terry. I appreciate it. All right, we'll move over to our STARS partners. Dale?
Phil, I could not agree more with the sentiment regarding the incongruities across grants and the challenges with bringing all of that together. We run into very similar on this side as well. And it's added to that, I would even add the fact that, you know, our Urban Area Security Initiative grant, because of the way that the state of Missouri has provided the Homeland Security funding through both the rest of the state and separated it from the urban area. When they did that many years ago, they created the urban area as an island within the healthcare coalition. And so there's this north-south Homeland Security division, and we have our healthcare, the HPP grant that covers all of those, right? So, or almost all of them, the urban and the north and the south. And so it has created a rather challenging across that whole communications footprint, because emergency managers and a lot of folks, public health even, hospitals in those north and south regions of our healthcare coalition much more aligned with the regional Homeland Security oversight committees than they do with the healthcare coalition. And so it's been a constant struggle, but then CRI, FEP, and the fact that FEP and HPP, as you mentioned, are supposed to work together on some things, but aren't always aligned. I would have to agree it's the feds that are causing the grief. And then, this coalition and our coalition, the fact that, we all have to work together, but there's that line, there's that big river, and the feds keep us separated. So, and the states. So yeah, it's I'm interested to hear more because y'all guys are looking to work on it. So be interesting to be a part of it.
Hopefully we'll get somewhere over the next 6 months to a year. I would say it would probably take us to fix some of these. But what else you guys have going over in Star?
We too, that whole pediatric behavioral health issue in particular, we did have back in for most of May, we ran a board for an EM resource that has long existed for folks to update that. There wasn't a whole lot of traction on it. But I think we've increased awareness that board even exists. But we too continued with the challenges. I believe most of our three primary healthcare systems here have figured out some ways of mitigating some of that, or at least dealing with it. The surges seem to have been dropped a little bit, but I think they continue on. They've just kind of worked out a process, kind of like any other long-term surge, COVID or anything else. It's let's work through it and move forward. So that's kind of where that sets right now. From you requested regarding vaccine information, there are not any large-scale vaccination clinics going on anymore on our side that we're aware of. The Missouri National Guard has closed all of their pieces. I believe the largest regular item going on is the city is doing some things with the International Institute, which is in South City. But otherwise, I believe it's mostly direct reach outs, EMS working with going into homes, some small vaccination sites at schools are still going on, and each of those are being supported by EMS, in some cases hospitals, along with their public health partners. That is from that side as much as we know. The state dashboard indicates that most of our region seems to have had somewhere in the at least the urban area part of our region is somewhere in the mid 30s for completed vaccinations. Our rural areas, both north and south, tend to be in the 25-ish, plus or minus a little bit, fully vaccinated. Our 5 largest counties have pushed somewhere close to 1.5 million doses out, which is pretty significant as far as the whole state goes. So that said, that's kind of where we are.
Thank you, Dale. Any questions for Dale? The good folks over in St. Louis?
Oh, the one other item, we have started planning for the PGA golf tournament in early September. Brad is over on that call as we speak.
Very nice, very nice. They probably can fish out some of my Top Shot golf balls that I've been hitting over there recently. I'm no longer a golfer. That was back in the 90s. Okay, thanks, Dale. Okay, Remer, Mike, any updates from the team?
We've been back to training and getting more busy with requests to doing training with other agencies. We've spent a ton of time over the last couple of weeks training with the law enforcement partners on different scenarios that they've been running. So just getting back to hopefully normal business for us.
Great. And as always, if you got any folks interested in being a part of REMERT, please reach out to Mike Gilbert or myself. We'd love to have you folks as a member of the team. You do not have to be clinical. Just got to be willing to put in some sweat equity sometimes, and because we always need logistical support as well. Okay. All right. Mental health. I don't think Dana's on. And Sue, unless you got anything major from the mental health team.
No, I don't have anything.
Okay. All right. We'll go ahead and move on. All right. Couple updates with regard to the grant. So questions that I been getting over the past month and a half, I would say, is can I spend my money? Can I spend my money? Can I spend my money? For those of you who have did submit grants for the FY21 grant. If you missed some of the hospital pulse checks or some of the other calls, yes, you're able to spend your money for the FY21 grant. With those of you who got an FY21 grant, you just can't bill until the new sub agreement is executed. So you can start to purchase, but you just can't bill until that sub agreement is executed. And that sub agreement will have the extension for you guys out through, I thought it was either November or December of this year. And that grant will fully close out January 31st of January 2022. Okay. So if you have a grant, you can spend it. You just can't bill yet until you have a fully executed grant back from the BJC GMO office. And cursory note, as far as the FY22 grant, the amount that we will receive is around $522,000. As usual, we'll start accepting project requests for the upcoming grant. So you will see a link with that going out here soon, so you can start putting in your project proposals for that grant. For those of you who don't know, again, $250,000 of that is kind of carved out directly for the RHCC, which partially funds my salary, partially funds Lee's salary. We've broken this down in the past. We'll do it again this year, but it partially breaks down for salaries and for the RHCC, the hospital, to basically fund those. How we run operations here with regard to preparedness, response, et cetera, surge, et cetera. And then the remainder of that goes out to you guys, or what projects that we're going to put on the books. Things that I would say that we're probably going to be taking up some money for, definitely, is to finish that KIMPAC exercise with these FY22 grants funds. We had $50,000 in the budget 2 years ago to do that KIMPAC full-scale exercise that we were supposed to do April of last year. COVID hit. We postponed it. We decided we weren't going to be able to do it literally the month prior to execution. So we're doing our final planning meeting and canceled it right before it. So we're going to dig that back up, and we're going to target trying to get it done April of 2022. So that'll probably take up. We paid $36,000 out of the $50,000 for what was done, and I presume that we'll probably have to pay another $30,000 to execute the final portion of that draft, maybe even upwards of $50,000. So I'll probably be earmarking at least $30,000 to $50,000 to make sure that full-scale exercise actually happens. I see you got a question from Sue.
Yeah, I was just calling. I just want to know, have you received any project requests? Because I thought you pushed out that link a month or so ago, and
Yes.
I submitted some, and I
Yep.
I didn't know if you had received it.
I did, and we did receive yours. I think there's a total of 7 project requests. Well, I'll just say 7 organizations total who submitted. And that's a mix between hospitals and health departments that did submit, as well as our REMERT team. And a lot of the REMERT stuff we try to manage here at Memorial, especially when it comes to like specific equipment, so we can maintain the equipment, et cetera, for the team. So yes, we did receive those, and as it looks right now, I crunched the numbers the other day. Let me see if I have it here with me. Give me one quick second. I submitted I put 2023. I probably meant to put 2022, but I put together a copy of that budget. Yep, looks like so. We received submissions from Calhoun County Health Department, Staunton, USU, Fayette County Health Department, Greene County Health Department, Monroe County Health Department. I'll just say the REMERT team, Memorial Hospital Chester, and Gateway Regional Medical Center. So 1, 2, 3, 4, 5, 6, 7, 8. Okay, so that's from 8 different organizations that we did receive them from. The total amount of all of those projects, just so you guys know, and I did include the salary stuff that we normally use, all of our must pays. And when I say must pays, those are things that we pay every year, whether it's Starcom fees, radio fees, Microsoft Office 365 access, all the things that we do every year that we can't get away from, D4H, blah, 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 because we have standing contracts. All of that totaled to $525,000. And I had that's just the number it came up to before I even knew it was going to be $522,000. That's also, just so everybody knows, that's also including completing our ventilator upgrade that we finished. We're trying to finish this past year. We bought, Mike, correct me if I'm wrong, almost $300,000 worth of new vents. Haven't received them yet. But this will take us up to having either 25 or 30 vents. Mike, help me out here. What's the total number of vents we're looking to have? I'm trying to look now.
I think with the reductions we had to do, we're getting either 19 or 20 on this round, and I think on the next grant cycle we're looking at 7 to add to it.
Okay, yeah, it's a total of 134,000 at least. That's what was on the submission for that. So that's a big chunk. So we do have a little bit of room to cut back some areas, by no means is the budget finished. And I can tell you right now, we're nowhere. And Greg, correct me if I'm wrong. We're not really close with egrams and everything opening up for submissions of budgets. We, again, just got the numbers maybe a week or two ago of what we will have to spend, and so I would not assume us having a budget for the 2023 until sometime, or 2022 budget, the FY 2022 budget, until again January, February of 2022. I could be wrong, but history has told a different story. So that's a long answer to your question, Sue. Yes, we did receive it, and just more information to come on that. And I know we did receive a few additional late submissions the other day, and we're going to try to look at those and incorporate them. But as of right now, as of what was submitted, I think we have enough money and wiggle room to knock these projects out. There may be one that we may not be able to accommodate out of the total submissions. Any questions, grant related? Any other questions? No? Okay. Supply chain integrity assessment. Okay, so
Phil,
go
I
ahead,
just
Greg.
had one question.
Sure.
So all of these are being presented and voted on, right?
Correct.
All of the money that's being spent outside of the 250,000 is being presented to the board members or the people on the executive committee.
On the executive committee, yeah. All of those get consolidated, compiled, and then prioritized by the executive committee. So,
okay. I just want to make sure that there's record that that's happening, because that's something that the auditors will look for. So
yeah,
I just wanted to make sure.
I normally submit that each, once I get it consolidated, and like I just did this before I went on PTO. So, yeah, once I'll have the full version of it, kind of broken down a little more digestible. I normally throw it in Access and print out a report, and then they prioritize them afterwards, and then we move forward. Luckily, again, like in these situations, we'll be underneath of whatever that money is, so we really haven't had to vie or fight or deny anyone unless it was against the tenets of the grant. Like, you just can't buy it with it. You can't get that with this money. So we have been very fortunate in the past 3 to 4 years in doing that. So and hopefully this year will be exactly the same. All right. Sorry. So moving on, supply chain integrity assessment. So you guys remember this survey went out. We got a total of 16 responses. That's it. That's all we got. 16 across all of our disciplines. I think we had 2 EMS services, some hospitals, and a few health departments. We really need more. I'll be honest with you, we need much more support than this. I'm really looking at maybe a number closer to 30, between 30 and 40 responses from differing agencies. So again, we're just going to have to extend this, double down again, and try to get more information back in. Again, I don't want to take a very narrow approach or narrow scope of information and try to compile that information, because it's not going to really say what it needs to say in the end. So a lot of this is going to take some hand massaging. So I'll talk to my resource hospitals. If you're on, again, I'll ask you guys, if you're listening, to go back out, beat the trees a little bit, talk with your EMS agencies, send them a copy of the link. I'll have to open it back up, but send them a copy of the link, have them fill it out, send it to your fire departments as well. Yes, who asked that question, CK. Yes, I am going to extend the duration or time for it to be, I'll extend it to the end of the month. Again, I really want as much participation in this one as possible. Again, we're just gonna have to get it out there. Hopefully we can get each one of the health departments to fill it out. I'd like to get a good swath of our EMS agencies to fill it out. And I know we have some very large EMS agencies, but even the smaller departments, it's important that we get that type of information from you guys as well. And I'd like to get some of the non-traditional or not just acute care hospitals or critical access hospitals, the dialysis centers, some of the long-term healthcare facilities. So we're going to have to go through these lists. I've got email contacts for a lot of these folks. And we've had to go through over the past 2 weeks and move folks out of the member planet because they're either not active, they maybe have started an account, and they work at, you pick it, nursing facility or nursing home, and but they're no longer responding. So we're going to have to kind of beat the trees a little more from my staff. But again, I'll ask my resource hospitals to reach back out to the EMS crews, the fire departments, places where they're, getting, so they can fill out this survey so we can really see what we're looking at. I'm not as concerned with our emergency management agencies, but I'd love for them to fill it out as well because they're non-traditional. They don't, they help out. They may have some stockpile somewhere of stuff, but they're normally not in the supply chain in that manner. They're buying one-offs. They're not getting supplies day in and day out. So looking for those healthcare facilities that are receiving or that are getting supplies daily or weekly, because that's where the impact is really going to be felt. So I will extend this out to the end of this month. But after that, I don't know what else we can do, but I need your guys' support to kind of help get us from 16, again, hopefully upwards into the 30s. I'd love to break 40. And that'll, I think, will provide us a little more fidelity and clarity on exactly what's going on in the across our region. Eric, go ahead.
Thanks, Phil. I'd like to take the soapbox for a minute. If you are a hospital and you haven't dipped your toe into this as far as a threat moving forward, I don't think you were paying attention. Sorry for the strong language, but just using the the survey that was pushed out from the region, and thanks to you guys for putting that together and pushing it out. With our facility, we recognize some gross weaknesses internally, just from us coming together as a group and completing that survey. So that was a huge flag. And if we add to that the region/coalition is going to take this information and possibly make some improvements, that's step 2. And then, the supply chain is a lot more than whether or not you got toilet paper at Walmart. It's just going to continue to be a concern. And the best way for us as speaking as hospitals is to take care of our own backyard. Secondly, I appreciate the fact that you open that back up. We'll open that back up because a lot of the resource hospitals, I'm sure like myself, have EMS advisory council meetings coming up. I have one at the end of this week, and I'll use that as an opportunity to strongly encourage participation. So that in and of itself should help our numbers, and I appreciate it, Phil.
Thanks for that, Eric. I like soapboxes sometimes as well. So as you can see in the chat, I have put the link. I do have it out open through 2022. So it's just open. Please feel free, share the link, push it out to your partners that you have direct contact with, and again, working with your team at your organization is greatly appreciated. Okay, it's not for me, and again, it's not for me. And while it is a part of our deliverables and things that we need to get done as a coalition, it's only going to help us in the end, get over some of the problems that we all experienced during COVID. So again, appreciate your time and patience and knocking that out. The COVID-19 AAR response survey. So some of you folks have started filling that out. So great. So we've got 7 responses received as of this morning. That form closes at the end of the month on the 27th. That link right there is good to go. You can use that to get at it. So please, any and everybody who has access to that link, please go ahead and fill it out. I did send out to the entire coalition a PDF version of the survey, so you can kind of work it. You can hand work it right there at your desk or across in a meeting, as Eric kind of alluded to earlier with his team, what he was doing. Round table it, kind of fill out, toss it around, say, hey, what do we want? What do we want to see as training going forward? That's the part of the improvement part of it. But we're gonna capture a lot of good information off of this, and then be able to really consolidate that information and make a bunch of moves going forward. I honestly believe that for the better. We were just talking yesterday here in the office, Eric, Lee, and myself, and maybe we've talked about it several times since COVID has started, but kind of really, when you look back, just objectively look back, go back and look at the plans that maybe you had for a high consequence infectious disease or pandemic planning, all of the stuff that you did for your vaccine, your setup for your mass vac sites, all of those type of things. I can honestly say some of the documentation that we had as an organization with regard to planning for a pandemic we did none of what was listed in that plan. None of it. I mean, maybe 10% of what was listed in our I'm trying to remember the exact title of it. It's called the Emergent Infectious Disease Plan that we had. And it was kind of a hodgepodge from what we had as a corporation, what they would call a core policy, and what we already had. We're trying to meet some, it seems like we're trying to just impress surveyors with this plan. But I would say it was woefully overdeveloped. and normally when you hear the word woefully, you don't hear something is less than. It normally sounds as though it's something that you are, you're missing the mark with because you don't have enough of. But it was so overly done that it did nothing for us. And getting some of your information back on this survey is going to help us tailor not only a better regional response in the future, but I honestly believe it's going to help us tailor or help you guys tailor all future responses with regard to whether it's pandemic planning or if that transitions to evacuation planning. Sometimes I think we just have a little bit too much word, and I'm talking to myself right now, and hopefully I'm preaching to the choir as well. But a lot of our plans are just too much. It's just too much information. A lot of times I think we want to impress ourselves with the words that we've put in these plans. A lot of it needs to be pared down. So, and that's something that I've already taken away from COVID in some of our planning stuff. And I try to make things as direct as possible, not to write things down twice, not to, to reference things and not copy things out of other documents. Those are, general planning principles that I try to abide by. But the overcomplication, the KISS principle really comes to mind with a lot of the plans that we had as an organization, as well as some of the things I look at across the region. So this survey is going to help us kind of fix those problems that I see, and hopefully you guys see some of that. Did anybody find when they went through this survey of somebody who has probably gone through here, go back and look at anything like that? If not, has anybody who completed this survey, do they feel comfortable talking about how long it took them or what information you may have garnered from completing this survey? And that's open for anybody who attempted or completed it fully. I wish I could make a good cricket sound because that's what I hear in my head. Nope. Okay. Well, what I gave as a 9 Mississippi there. I will I'm encouraging everyone to knock this out as much as they can or as quickly as they can. Because I want to have our follow-up conversations of this. So we'll be looking at host some teleconferences in the month of July. So at least probably maybe 2 weeks apart, talking about the information that we got in here and starting to consolidate that into an actual full AAR for the region. Okay, I really want to make it targeted for the region and hopefully give you guys something to assist in all of your future planning, specifically for pandemic response. So patient decon training. Oh, picture, I forgot to post that picture in here. I apologize, but we're targeting September as a start date to start doing training again with regard to decon training, for patient decon training. So if you would like to host a class, if you would like to host a class at your organization, please reach out to either Scott or Lee. Those hyperlinks in there go right to their email addresses. So if you've got a copy of the slides, you can click on that and email them. Please reach out and say, hey, we'd like to get back to doing what we do.
Gateway down.
All right, Rick, good. I know Lee's been working with you guys in the past, and we appreciate you guys for hosting in the past as well. So definitely we'll be reaching out to work with you guys in Gateway. But we know that it's been a little over a year since we've done a class, but the requirements are still there and the threat is still there. It still can happen. COVID didn't stop any decon events. You probably just had less of them, but it still happens. So we are working on developing a physicians only course that's really pared down. That's kind of a what you need to know as a physician decon course. We understand that a lot of physicians we're not going to get a full 8 to 10 hour day out of them. Some we will. They're not going to attend the regular course, but we're trying to create something that is geared towards physicians, a little less on the a little bit less on the PPE and all the other things, the guidance and all that stuff that you get when you go through it, it will not qualify as operations level, training per the CFR, the Code of Federal Regulations, but it will put them in a better position to be informed. Our physicians are smart folks. We're not saying they need to be rocket sciences as well as doctors, but a little bit of information goes a long way for some of our physicians out there. So to keep them on the same page as your decon teams are, that's the goal of this class, and to make them more effective in the treatment of patients during a decon event. So while protecting themselves and the house, as I like to say. So we're also working with our coalition partners across the river in St. Louis to take our decon training class and make that kind of a standard. So we're trying to do that. We've been trying to do that with BJC generally. It's been a long, lots of conversations. I know Lee's done a lot of work working with BJC, but we'd like to make that the standard across both sides of the rivers. We think our course is good enough, and only thanks to your guys' help in helping shape that course, build it, and get it to where it is today. Sound like somebody wanted to say something. I'll pause for a quick second.
Did you tell Tara? Chandler has it.
Oh, so I hear somebody's got their mic's hot. So
Emailed me and asked if I'd heard anything. I'm like, no. Like literally.
so we'll move on. Any questions with regard to patient decon training?
Monroe County on their vision.
Hey Phil, this is Eric. I was wondering, what is the minimum number of attendants to host a class at the hospital?
So we'd like to have a class with with at least 10 folks. That's we've done as little as 6, when we're really stretching. But especially if we're going to travel, a minimum of 10. And if you're going to host it, it's easier to host one and then get folks, even if it's not just from maybe, your team, but it may, be coming from other locations. So it's easier to do that, and if you get it out in far enough in advance. So 10 is a minimum.
Nobody can update it.
Okay, thank you.
I haven't seen it. Yeah,
There we go. I got the ultimate mute button there. Okay. All right. So thanks, Eric, for that, and definitely we'd love to host a class there. We try to, just so everybody knows, if you don't recall what the original kind of plan was in the past, we would do 6 here at Memorial Hospital in Belleville, primarily due to the facilities that we have here and having a large area for decon. It's not the most convenient area when it comes to getting from the decon area to the ED, but it is large and we can have a lot of folks there. For our roving classes or our traveling class, we'd love to be able to do them all in the spring and summertime and early fall and take the decon trailer out there, but that's not always possible. But in those instances where we don't do that, we just use your facilities and go through your kind of standard operating procedures, help you guys with what you guys do there, and try to host, at least 3 to 4 of those along with the 6 that we host here at Memorial Hospital. So 3 to 4 road trips is great. Again, while we're here and still in COVID mode, we're going to still try to do the same thing, but just a little bit safer going forward. So, all right, last few slides. This thing says Capper Alternative. So some of you as part of some of our washout funds, we procured 25 Halo positive pressure tight fitting respirators, as you kind of see here. Just a couple images from the Halo website. We talked about this maybe a month ago on one of the coalition calls or weekly updates or weekly pulse checks. We did a training class 3 weeks ago with the good folks at Clean Space, and it was done very well. We did it remotely. but it was done very well. We invited some folks, our infection prevention folks, our OC Health folks, and a few others. Unfortunately, it wasn't super highly attended, so we had it was 3 or 4 of us for the class. But our OC Health team and I can already say that my infection prevention lead here found that these fit great and looked like to be a great or potential alternative to traditional cappers or definitely pappers in specific instances with regard to non-chemical or anything like that. But when we're talking about infectious disease stuff, so COVID or what have you. So just a few notes on here. These on-demand air, just so you know, this is all on-demand, positive pressure, up to 9 hours of battery, assigned protection factor of 50, and that's without the actual motor running. So if the battery dies, you still have a assigned protection factor of 50 and upwards to 1,000 in this specific mask. There's no hoses. And what you see is what you get right there. It's extremely light and comfortable. I've worn them several times now, and it helps in various situations, specifically with regard to when you start to talk to one of your patients, as it does have a clear nose cup, as you can kind of see there. So that always helps when folks know that you're talking to them, especially for those who are hard of hearing and need to read lips sometimes. It does help in that regard as well. There's also a sterile, and I see your hand, Eric. I'm going to get to you in 1 sec. There's also a sterile exhaust exhalation filter that can be placed on top. So if you're working in sterile settings versus just a traditional setting, you do have to wear either visor or goggles or safety glasses, whichever that you would have, to meet probably your infection prevention requirements at your local organization. But we purchased these as a potential backfill for when we have these type of events and like a pandemic, or we have an Ebola or something else, where we use pappers and cappers and those type of things, because these seem to be lighter, leaner, easier to dish out and easier to put on, because one person can do this in a matter of seconds versus what I see when I see folks in tandem with cappers and pappers. So we are not endorsing this product, as we want you to buy. We got some of these so we can test them out across the region. So we're putting some in the hands. We're going to probably have 6 here at Memorial or so. And we're looking for organizations and both EMS and hospitals to try them and give us some feedback to see if this is something that you would be willing to test out in your organization, just to give us some feedback, because in part of that whole supply chain piece, we see some merit in how this is managed and the ability for us to kind of use them as a force multiplier when cappers and pappers and the like become hard to get a hold of. So I'm going to pause right there. Eric, I know you had your hand up, Brandmeier. So do you have a question or comment?
Yeah, I had a question. I must have been on the one meeting I missed. I didn't catch this happening at all. It's exciting though. So there's no, I assume, there's no fit testing requirement for that?
Unfortunately, yes, there is, because it's
I thought there might be. It's still a mask.
So yeah, because it's still tight. It's still considered tight fitting. Now, they're still working, or I don't say arguing with OSHA, because it is positive pressure. So this is kind of the thing, because it is still positive pressure. I believe, just my professional opinion, is that it should not require fit testing because it is positive pressure. If you are to, on that mask, because it's on demand, if you were to put you can't see it now, but if you were to put your finger between that nose cup and your nose, it will immediately start blowing as hard as it can filtered air to you without you even having to breathe. Like I said, it's on demand. They have a guy who ran a marathon in these in 4 hours, in one of these in 4 hours. But as of right now, the requirement is yes, you still have to do fit testing. That's either quantitative or qualitative. So you can hook them up to a machine, or you can do standard chloride, or whatever you choose to do, banana oil, or whatever you do at your organization. I know someone just put something in the chat. Let me just see what that says. I'm sorry. Sue, could you send me an example of this product? Oh, yeah. So what we would do, just so everybody knows, what we would do if you would like to potentially test this out, we would ask that, it's not just you, that you were basically commit to having at a minimum someone from your nursing team and your infection prevention person present. We will send you one or a few of these, and then we will host a training, because that's what we did our trainer for, or we'll have the good folks at Clean Space host another training and allow you to ask questions, put it on, test it out, and do what you want over the course of a couple of months, and give us some feedback and how you think we could fit this into our regional cache, if you will. So again, not trying to, and again, I'm not trying to sell you on something to go buy directly yet. I'll say that yet, but if we can find merit in this as a potential alternative, I think this may be something that can help us in future endeavors. I know that my EMS crews would rather wear this in the back of an ambulance going up to Chicago for 6 hours or however long the trip takes. So I know a lot of those guys and gals would like to have something like this instead of being in the back with the N95 on, pressing their face pretty hard. Oh, is that John? John, you're supposed to be off, man. Go somewhere. All right. That's what John Nowak said. Yes. So yeah, so definitely. Hey, Steph. Yes, the Maxxair capper. Yes, we had some Maxxairs. The only reason, I won't say the only reason, the reason why we kind of started to look to an alternative is that we found that there was a lot, when demand was high, everybody had to have those parts and pieces. And we found that and a lot of times the cappers, the Maxxairs, they weren't as durable. I guess that's the word that I want to use. They were not as durable as I would have liked. And again, a lot of them require multiple sets of hands, a belt, a big battery pack, a hose, things your mobility became restricted. So again, we were looking for something that kind of answered some of those questions with regard to durability. And we kind of found something that answered questions that we didn't think about, like having a buddy system all the time where you need to have monitoring a little bit more. So those were some of the things. Yeah, I know. I agree, Steph, that yeah, the fit testing requirement. But again, we've invested some time, money, and effort in our fit testing here. So I think it's until that requirement goes away, which I hope it can go away. I think it's a well worth of an investment if you do that as a part of your onboarding and just get people done, because you can just this whole unit isn't just one unit. So that nose cup comes off. That nose cup is just separate. It's a separate supply, and you can still fit test a lot of folks. So it's not a one and done. But if you're using N95s today, you guys are doing fit testing today, right? So exciting opportunity. So if you would like to be a part of it, and we can assist you with doing that. And Scott put in there in the chat, yep, it does have a full face. They have a whole bunch of different options here, even the industrial side. So if you have, so Rick, if you got any of your systems folks or any of the folks in the plant, and if you're doing any industrial stuff, they've got some industrial versions of these that are really pretty cool too. So these are the medical grade ones. Again, I'll just tell you, very comfortable. It's super quick. Takes maybe 8 seconds to put on. And we used to use the 9-second rule in the military. We're putting your mask on, and this, you can get done in less than 10 seconds. Super easy. All right. So again, email me, Sue. We got you pinned as a potential. So Eric sounded a little excited. So if you are, just let me know. Chuck, John, or Leslie, or any one of the EMS agencies, if you'd like one or two to test out, more than happy. Again, make sure your information control officers are part of that training, and we'll definitely be willing to host it. All right. Lastly, these are, that says Cap, I apologize, Capper Alternative at the top. This should be the RDS disinfection system. We procured 7 of these to assist ambulance crews and hospitals who may be experiencing some EVS issues, to help, turn rooms a little faster when we're in the middle of a pandemic or anything like that, any HSID, Ebola, or what have you. So these systems here are both manual and automated. You can kind of set it and forget it in an ambulance, set it and forget it in a room of a specified size, let it run, go in, do whatever wipe downs you need to go, and then move on to the next room. And we've already been in contact with the good folks at MedStar. Well, we're going to get them at least 2. Again, resource hospitals, we'd like to get you 1 or 2 of these so you can have them for your EMS crews and or the hospital. And just like with the Halos and these, the goal is to actually have these out, or the ventilators, I shouldn't say the Halos specifically, but the vents. We've talked about this in the past. We've got those new vents coming. We're going to have them out in the community, on ambulances, in hospitals, so we can have folks that are functionally aware and can use them and provide just-in-time training from expertise. It's nothing worse than, again, getting a new piece of equipment at the time of need and then trying to do just-in-time training. When you have somebody who's been using it at an ambulance base for, months or years, they can come in and go, hey, yeah, if you want to use this, just push this button, do this, change it every, so many uses, and then go. It makes it a lot easier to deploy assets like these. So these are here. I think we've got them in D4H this past week. So thanks to Lee and Eric for working that out, getting everything there. We're getting the Halos in D4H as well. But these right here will be available. So outside of MedStar, if you want to host one of these, please reach out to us. We're going to keep at least 2 here, 2 at MedStar, so that leaves 3 to go back out to the region for any other organizations that would like to use them today. So please reach out. All right, that was a lot. I thought this was going to be kind of quick. So here, let me open the floor before we look at that last slide. Questions, concerns from the coalition, anything? Nothing.
Hey,
John.
Phil, it's John Nowak.
I hear you. Those birds almost sounded like crickets, man.
Hey, I'm sitting in the mountains of Hot Springs, Arkansas, taking a break from my vacation. Hey, I got a real quick thing. It just kind of goes over all of what I see. Of course, I get in Hot Springs, and Phil, you know me pretty well, and I think most of you out there that are on here know me pretty well. I'm pretty involved in what we do with our region. So, of course, when I go to other areas, and I don't get to do it very often, but when I do, of course, I'm nosy and seeing how things are going here. I just want to say, I know we got a lot of work to do, and I agree with you totally on the planning stuff you were talking about earlier. We got a lot of good plans that we don't use, or we make too big and we can't use them at the time of an event happens, because you ain't got time to read all that. But anyway, where I'm going is I want to tell y'all something. I'm very proud to be a part of where we are and what we do, because I can tell you where I'm at right now, they are still in a massive an event going on here with COVID. This morning when I checked here, they still had over 900 patients on vents in this state. What we've done together through Illinois and the St. Louis side, is unbelievable. So I just want to say again, I know I've said it before, but I believe this team and this coalition has done an outstanding job of keeping things together. No, we haven't been perfect, and I think we have a lot of room to grow. But man, it's amazing the difference between home and other locations. So if you don't ever do that when you're out on your own and out visiting other places, you probably ought to, because you would really, it would open your eyes to see how well we do things and how far advanced we are. And again, I would just like to thank everybody for that. And I'm very proud to be a part of that team. And that's all I got. I'll go back to vacation.
Well, John, thank you so much for the kind words, and I'll echo those sentiments. Much appreciated, brother. And it's good folks like yourself and lots of other folks here on this call that are willing to, put in the time, the effort, and see the vision of trying to make something a little bit better. Sometimes it may be slow, it may not come as quickly as you want it to, but we'll get there. We'll get there, but we'll get there together. So thank you for that, John. It's always good to hear those type of words. You're appreciated. Anyone else? As John drops the mic, going back to vacation. Anyway. All right. Okay. So great. We'll go ahead and kind of close her out here. Upcoming events. Again, I'll say now we're going to suspend our weekly hospital pulse checks effective immediately. So obviously not today or this afternoon, but next week, no pulse check. If you have an issue, please just reach out to myself or Lee directly. We'll work with it. If things start to heat back up, and I'm saying this in the course of where we're at with regard to COVID. If we're shutting down as the conversation's gone, we're shutting down vaccine sites while we still have some going on. That's not a big demand right now. COVID volume is down. We'd like to give you back more time to kind of pick up the pieces and put things back together from what you kind of learned thus far. So next meeting will be the week of, I think it's July 7th. Yep, it is July 7th. Will be our next week, our next meeting. We always come around this time frame, and it's 4th of July, and I'm always worried that week is kind of a bad week. So while I got folks here, would anybody care if we kept it there? Would we rather keep it there? Or would we rather kind of go out to the 14th? What are your guys' thoughts? I'll just open that as a question.
Gateway's okay with where it is.
So is Anderson.
Okay. If I don't hear any, if I don't hear any other, choices, then we'll keep it as a 7th. Okay. That regional AAR again closes out. That survey closes out on the 27th of this month. So please get that done. Decon training, again, we're targeting September. Good folks like out of Gateway, Touche, if you want to be a part of that, let's start working together now and getting some stuff on the schedule. We also, I will just throw this out here, we may try to build, because again, we're trying to work with our partners in St. Louis. We're gonna try to put together a public registration and search site. So you guys can register for classes on site, on a website, and then search for like certificates. If you had to print up someone's certificate or get a date for someone, and getting, that, oh, I know they went through your training at some point in time, or maybe they moved they go from here, from Belleville, and then go over to Christian Hospital, or go to Anderson or Boyd as a nurse, and they want to say, oh yeah, I got that training. They can go back to a website and kind of get that information. So it may take us a couple months to get that done, but that's something we're going to be targeting. But we want to get that class started, hopefully by the month of September. Other big events coming up. Again, the IEM, the International Association of Emergency Managers, is 15 to 22 October in Grand Rapids, Michigan. Beautiful location where they held it a couple years ago. The weather was just super crappy during that time frame, but a great location nonetheless where they held it, and I believe they'll be holding it in the exact same location. So if you guys are interested in attending that, it's in October. Registration, I believe, is open now. And the National Healthcare Coalition Preparedness Conference is in Orlando, Florida this year. And again, that's end of December. They always do it the same way, end of December, end of November, beginning of December every year. So that's another great one to attend. Sue can attest to that because she has been down. I think where were we at, Sue? Was it Houston or wherever? That was a good event, a very good event that year. So if you don't have anything for me, we'll call it an end here. I'll give you back 29 minutes of your day, and we will talk at you on the 7th of July if we don't talk at you sooner. So thank you very much for calling in, and we'll see you then. Take care.